So it's always important to have a multidisciplinary assessment for patients with lung cancer, and this case kind of highlights the challenges. This is a patient who derived a benefit from chemotherapy, had stable disease for close to a year, who then had a new lesion. I think it's reasonable if a patient is fit and has a new lesion or a new mass in the setting of overall stable disease otherwise to consider biopsying that lesion. One, it may be a different cancer. Two, you may be able to figure out the genetic underpinnings if it is a different cancer. And so if patients that are fit who have derived a benefit from chemotherapy, who've had stable disease for over a year, I think it's reasonable to identify what's growing. And that was what was done in this case. Once the biopsy was performed and we identified that this was squamous cell, this is where the real critical assessment begins. Do we necessarily consider that progression given that all other sites of disease in the body are stable? Does that mean we pull the trigger and move to a second type of drug or immunotherapy? Or do we consider local ablative therapy? And I would make an argument for a fit patient who's had stable disease and other sites of disease for over a year, who has one new spot. I think it's reasonable to consider local therapy. But just this highlights how important multidisciplinary conferences and tumor boards are to have these discussions, to have the surgeon in the room, to have the radiation oncologist in the room, to have the medical oncologist in the room, to have the pathologist and the radiologist. Lung cancer has gotten so complex. And we've got so many new therapeutic advances, not only in the systemic realm, but in the local ablative realm and the surgery realm, that everyone needs to come together in either a shared virtual space or physical space to discuss these patients, and the patients deserve it. I think maybe 5-10 years ago, this patient would have gotten chemotherapy, second line, and I'm not sure this patient at that point with just one growing spot warrants systemic treatment that may cause more side effects. So I encourage all patients that if any nuance of delivery of care, especially as they progress, and especially in these cases of oligometastatic disease, we really consider them to be candidates to discussion on a multi-tumor board, a multidisciplinary tumor board. The treatment paradigm has dramatically been altered in the past 2 to 3 years for squamous cell and for all non-small cell lung cancer. I think 5 years ago we would have offered docetaxel or another cytotoxic chemotherapy. We now have very good data, multiple phase 3 trials, showing that immunotherapy is superior to chemotherapy for patients that are chemorefractory. And I guess the first question is, well, when do we make that decision? When do we decide to institute immunotherapy or any second-line drug for that matter? And I think this treatment decision has to be individualized. You have to look at the patient and ask yourself, what's the overall burden of disease doing in that patient, and how symptomatic are they? And every patient is different. And I think it takes a real critical assessment to understand when it's time. But if I see a patient who has worsening symptoms and I have radiographic evidence that the cancer is growing, it's time for a therapeutic switch. And that therapeutic switch off of a clinical trial is usually immunotherapy for most patients. Now, not all patients are candidates for immunotherapy, and we need to remember that. Patients with autoimmune diseases, patients on steroids, they may not be the best candidates. For many of our patients, however, we now have 3 approved drugs in the chemorefractory setting for squamous cell. One is nivolumab, and nivolumab has come around first and certainly shown an improvement in overall survival compared to docetaxel. Second is pembrolizumab. It also showed a benefit over docetaxel. And then finally, atezolizumab, which most recently showed a benefit over docetaxel in terms of overall survival. So we have an embarrassment of riches. We have 3 drugs. 2 are PD-1 drugs, pembrolizumab and nivolumab. The other is a PD-L1 drug, which is atezolizumab. All 3 are approved. I get a lot of questions from community docs and from other physicians asking me which one is better. We have no direct head-to-head comparison between these. I think all of them work very well. All of them can be used, with the exception of pembrolizumab, which still requires a PD-L1 greater than 1%, not 50, but 1% in the second line. Both nivolumab and atezolizumab don't require PD-L1 testing. PD-L1 testing now is going to be done up front anyway, so you're going to have that information up front. If they're greater than 1% up front, of course they're going to get chemotherapy, but then they can be candidates for immunotherapy, either pembro, nivo, or atezo in the second line. If it's 0% up front, of course, they're going to get chemotherapy, but in that case, Pembro can't be used. You can give atezolizumab Tecentriq or nivolumab Opdivo. So it's confusing. It's very confusing, but 3 drugs in the second line. Atezolizumab and nivolumab require no PD-L1 testing. Pembrolizumab still requires a PD-L1 testing greater than 1%, which is different than the 50% needed up front to give that drug.